Good evening, everyone. My name is Shauna Sylvester, and I have the privilege and pleasure of serving as the Executive Director for the SFU Public Square, just one of the hosts of this evening's gathering. I want to begin by acknowledging that we are in the traditional territory of the Coast Salish people. I also want to talk to you a little bit about how tonight is going to proceed. We have the opportunity of hearing from Howard Sapers. Our president is going to give us some welcoming words. Professor Neil Boyd is going to do a bit of an introduction. May Burrows is also going to be providing some context. Then Howard will have a chance to speak. Then we'll be seated here, and that's the chance to really enter into a dialogue. And I'm going to keep my questions to a minimum so that you have a chance. I know that there's a great deal of expertise in the room. Now, one of the things that we generally do at an SFU Public Square event is we mix it up a little bit. So what I'd like you to do is turn to somebody near you, ideally someone you don't know, and tell them why you decided to come tonight. So just take a moment to do that. I hope you've each had a chance to just introduce yourself at the very least to your neighbor. We are webcasting this evening. And as you'll note, there's a camera there and there. If you're someone that really does not want to ensure that your picture is on that camera, just please let our camera people know so we can try and avoid that happens in the final webcast, or in the final video. I also want to let you know that if you are a tweeter, do we have any tweeters in the group? There is a hashtag, and it's SFUPS. And there are people that watch what's going on who couldn't make it through that, really difficult snowstorm we had today. Amazing what happens to the city of Vancouver when snow happens. It is my pleasure tonight to introduce to you our president. I have promised him I will keep this very short. Promised. But I do want to say a couple of words. Andrew Petter, for those of you who don't know him, has a long tradition and history working in legal issues. He was the Dean of Law here at UVic, and he was our former Attorney General, among many other cabinet posts that he has brought. He's now our President and Vice Chancellor, and I know that he brings this issue up, has a real concern and interest in this issue. So, Andrew, over to you.
Well, thank you, Shauna. One of my real pleasures as president is I get to drop in and welcome people to events like this, and then stick around and get some intellectual nourishment and benefit from the dialogue. And so let me do that. Let me welcome you to the Goldcorp Center of the Arts, which is a very important part of our vibrant downtown campus of Simon Fraser University. I'm delighted that SFU is able to host this public dialogue with Howard Sapers. Howard is in town for a number of reasons, one of which is he's going to be receiving an Outstanding Alumni Award, which means he is indeed an SFU graduate. So it's great to be able to welcome him back to SFU. And we're very grateful to him for taking time while in Vancouver to also participate in this forum. As Sean has indicated, this is part of SFU Public Square. Some of you may know that SFU Public Square is an initiative we launched a couple of years ago as part of our commitment to be an engaged university. And what does that mean? It means a university that is really there for the community and is there to provide a forum for dialogue of this kind and to try to benefit society in every way we possibly can. The un-ivory tower, if I can put it that way. The purpose of SFU Public Square is really for this kind of dialogue, to bring people together, to have important conversations about our community, about our society, about what really matters to us, and where we should go in terms of shaping a better community for ourselves and for others. Tonight, we're going to explore issues of mental health and addiction amongst Canada's federal offenders. It's a very important topic and one that I'm delighted that we're able to spend some time reflecting on. And let me just say that as with so many public square events, these events don't just happen. They require a lot of support, and we have some support from very supportive community partners who've made this dialogue possible. They include SFU Alumni Relations, the School of Criminology, the Van City Office of Community Engagement, SFU Woodwards, From Grief to Action, and Brave, the Mary Steinhauser Legacy. And I'd ask you to please join with me in expressing our appreciation to those partners, or we wouldn't be here this evening. And now I want to introduce someone who's going to help to put tonight's discussion in context, who also happens to be a past winner of an SFU Outstanding Alumni Award, as well as a remarkable community advocate and organizer, and that's May Burrows. And many of you will know May. You'll know her by her accomplishments. I won't go through them all, but a few. She's president of the Family Support and Advocacy Organization From Grief to Action. She's done extensive work building bridges on a range of issues between environmental and health groups, workers, NGOs, and governments, and universities, I might add. And her current focus is on improving the health of people struggling with addictions and mental health issues and supporting their families. So with that, please join with me in welcoming May Burrows. May.
Thank you very much for that nice introduction. And thanks everybody for coming out on this very snowy night. I'm here representing, as Andrew said, an organization, a family advocacy and support group called From Grief to Action. Our experiences of how addictions and mental health are treated by the system will give some context to Howard's talk later about what happens when these people have got a go-to-jail card and end up in a federal prison. From Grief to Action started in the 90s with actually a group of West Side families who found that their kids had become heroin addicts. And so they had to start trying to deal with that experience, and they turned to each other for support and for understanding and to try to see how it is that they could help their kids. And they did give each other support and understanding, but what they found is that there's an enormous amount of gaps in the system when it comes to treating mental health and addictions. And they also they came to understand the enormous stigma that's attached to it that becomes a huge barrier to treating addiction like a health issue. So they joined together and formed a group and moved from grief to action, and now we're a fairly important advocacy group on the provincial face. We have three key messages. Our first key message is that addiction is a health, not a moral or a criminal justice issue. And I'm sure everybody in this room would agree with that, and probably an awful lot of other people. But then I want you to think about, why is it that addiction is so often treated outside of the healthcare system? It's treated in really high-end, expensive treatment centers for some people. It's treated in really marginal kind of treatment centers for other people. It's always a pay system. Sometimes health authorities will put a little bit of money into it, but it's not something that you see a heart patient or a cancer patient have to do, to take out loans and, go into their savings to try to go and get what they call treatment for addictions. So we want to start seeing it treated as just a health issue. And part of the whole treatment piece is post-treatment. Like, you have the detox, you have treatment, you have post-treatment, and then you have many years of support afterwards that you have to give people. And what we see with a lot of the post-treatment are these things like support recovery houses, which you may have been reading a bit more about in the newspapers recently. If you want to know how to run one, just Google support recovery house, and then you can find out how to run one, because it'll give you instructions on Google, like how to set it up and, how much to budget for rent and stuff like that. You don't really need trained staff. You don't need really a facilities or an operational license. You can just set up a house in a residential neighborhood, and then you can get 20 guys to come and live in it, and you don't have any staff. But you sure have somebody there to make sure that somebody's collecting the $375 a month for the rent welfare checks. That's what post-recovery support is in this province for a lot of people. And what ends up happening is that a lot of people that go into those centers oftentimes come in contact with even much more harsher drugs, come in contact with a whole kind of drug culture and dealers and all of the stuff that goes along with that, including a go directly to jail card to do the criminal activities that they have to do in order to support their addiction. So many of these houses are well run. I don't want to paint them all with the same brush, but I think it's deregulation gone amok, and it's not health care. One of our second issues is that there needs to be a lot more attention paid to concurrent disorders. Many people with undiagnosed mental health issues don't even understand what's happening to them, don't even know that their experience of life is different than other people's, and that even makes them more frustrated and down on themselves because they can't seem to cope as well as other people do. So what starts to happen oftentimes is a self-medication with illegal drugs that soon turns into a criminal addiction. So what we would like to see is a lot more diagnosis and treatment for concurrent disorders. Even when people do realize that they need some mental health care and they go to the mental health offices, they're often told, come back when you're clean. Come back in a couple of months when you've quit using, and then we'll give you mental health treatment. And of course, we know that that doesn't work. The two need to be really treated side by side. I live in Burnaby, and we have exactly 1/2 a position for a concurrent disorders counselor in the third largest city in British Columbia. So you can see there's a pretty big lineup at her door, and we could do a lot more of that. And in the whole Fraser Health area, which is from Burnaby to Hope, we have one detox center, and detox is just the beginning of a very long process, 5 to 7 days maybe, just to kind of get a bit healthier. So there's 22 beds for anybody that needs that from Burnaby to Hope. 3 to 4 wait list, a 3 to 4 week wait list isn't a very good way to start a treatment program. And then often what happens in these treatment programs is just like my way or the highway by the head doctor, whoever's started the center of the treatment program. And one kind of treatment doesn't work for everybody. No one size fits all. And so we want to see a much greater diversity of treatment for concurrent disorders and addictions treatment. And we also want to see families stop being as stigmatized as we want to see people with mental health and addiction issues not stigmatized. We've got to stop the shame and blame game on families. It reinforces an incredibly debilitating stigma that just stops anything from happening. We mustn't start with what we have currently, which is the assumption that families are a liability. Many families are an asset, and you have to sort out which is which and not just start from the shame and blame. And families need support when they're going through this kind of absolutely bewildering nightmare that starts to happen in their loved one's life. And families need to know they're not alone, and we don't really support families. We just assume that they're severed somehow once somebody becomes mentally ill or addicted. Mental health and addiction isn't just a downtown east side issue. It's an issue for all of us. And people in the downtown east side have a really hard time because they're more fragile and there's far fewer filters. But, let's face it, everybody probably has in their family someone who has an addiction or a mental health issue, and we've got to start telling our stories out loud, to start fighting this stigma and to start changing people's assumptions that mental health and addiction is some kind of really awful thing that should be stunned. And we really have to make some changes in the system. And we can do that with a lot of the current budgets that we have if they are reallocated in a more intelligent and humane way. And I want to just point to that poster in the back room. The back of the room, the Mary Steinhauser Brave Legacy, they are also sponsors of this event. And Mary Steinhauser was somebody who made a big difference. She and I both worked in the prison system in the 70s. We carpooled together out to Matsqui. Mary was a social worker, a nurse, and a really brave, compassionate prison reformer. She understood that prisons weren't just for punishment, but also for deterrence. Not just for punishment and deterrence, but also for rehabilitation. She understood the importance of families, and so she started family groups. She understood the importance of outsiders, so she had outsider groups operating in the prisons. And then she did some really radical changes to solitary confinement, which still happen today, solitary confinement, where people are put in a cell by themselves for years and years and years and years. And we do that to human beings in this society. So in the day, when we were out there, the only thing people were allowed to read in their cells was the Bible, if they're in solitary confinement. And Mary won them the right to read. They could read other books, and they could even do correspondence courses in their solitary confinement cells. So please take a minute to Mary Franz. Margaret Franz, Mary's sister, is here, and she started a bursary in Mary's honor. And they have a wonderful event coming up in a couple of weeks in Mary's honor. So pick up a couple of tickets to the event and learn more about Mary. And please consider making the Mary Steinhauser bursary one of your favorite bursaries at SFU. And now my final thing is, so let's see, Sean introduced Andrew introduced me, I introduced Neil, and then he's going to introduce Howard, and then I think we're good. We're good to go on the introductions. So I get to introduce Neil Boyd, who is the head of the SFU Criminology Department, and many of you already know him. He's a credentialed scholar and a prolific writer, including author of many, many articles, reports, government reports, and so on, and 7 books, which is quite a few books to write. And one of them is called 1,000 Dreams, Vancouver's Downtown East Side Fight for Its Future, now in its 5th edition, which is pretty amazing, I think. So on behalf of SFU, I'm really proud to introduce Neil Boyd, a leading thinker, researcher, teacher, and commentator. Neil.
Thanks very much, May. That was overly kind. I'm really pleased to be able to introduce Howard. We've had many graduates in the 35 years that I've spent at Simon Fraser, and Howard is one of those people that you hope for. You want your graduates to be more like Howard, and I'm sure there are some in this room who are somewhat like Howard themselves. But Howard's he graduated with an MA in criminology. He went on to become a Liberal member of the Legislative Assembly in Alberta, which is a lonely task in itself. So I think he's been pretty courageous in a lot of the roles that he's taken on, perhaps none more so than the 10 years he has spent as the Correctional Investigator for Canada. And he tells me that his term expires on, or actually the anniversary of the 10 years comes up on April Fool's Day. And the government may reflect upon its judgment, but certainly not us. And I'm extremely pleased to be able to introduce him. We have a gift for him. Normally, of course, you present gifts at the conclusion of a talk, but I have such confidence in Howard's ability to thrill us, to enthrall us, that I'm going to present him now with this cornucopia of SFU memorabilia. I've seen Howard speak before. Many of you have as well. And he combines humanity with analytical depth and detail. And we can only hope that more people will listen to the message that he has. Howard.
It's wonderful to be here, and I really mean that, even given the snow. And I am thrilled that there's actually an attendance. As I was driving back from Surrey in the fog this afternoon, I said, there's not going to be anybody there tonight. And you proved me wrong, and I thank you for that. And I really do want to thank the organizers. This is it's a very important week for me. I'm quite looking forward to the ceremony and on Wednesday, and just being part of the SFU family is very important to me. I need to correct one thing though. Full disclosure, I never defended my master's thesis, so I don't have an MA. I actually deserve it, but I don't have it. And well, you're here, Mr. President. Perhaps we could chat about that. But I don't want anybody, saying that. I don't want to see a headline that I misrepresented my CV and my moving expenses or something. So just make that clear. One of the sponsors, of course, tonight is Brave, and you've heard a little bit about Mary Steinhauser, and you've heard a little bit about how her memory is being honored, and that makes this a very special night as well. And so I am really thrilled that this combination has come together, and so thank you to all of the organizers. The event this evening is advertised as a dialogue, and it probably doesn't feel like that right now. Just some other guy in a Ty talking at the front of a room, but we are going to get to a dialogue, I promise. There's going to be lots of opportunity for questions, and I hope some discussion about perhaps even opposing points of view. I want to address primarily three things in the 2 or 3 hours that has been allocated to my presentation, and I'll try to get through them as quickly as I can, although as you can already tell, I get distracted easily. It's another reason why the thesis never got defended. But anyway, in all seriousness, you know, this is going to be some tough sledding this evening. Very, very serious issues, and I have lots of numbers. I really want to set a stage for the rest of the discussion. So there's going to be some numbers, and I'm going to run through it fairly quickly. Any of the material that I refer to tonight, any of the information that I'm sharing is accessible on our website. So the Office of the Correctional Investigator website, if you Google that, you'll eventually get there, even through the new and improved Government of Canada website, which doesn't, anyway, it's not easy to navigate if you find it, but you will get there, and any of this information is available. I did bring some material with, and it was put on the table at the back. I think a number of you have already helped yourself to it, but that's all. You can get that in digital copy as well. So tonight, talking a little bit about the burden of the incidence of mental illness and addiction in Canadian penitentiaries. Also want to talk about that in Canadian society. I want to talk about some of the larger issues that bring people into conflict with the law that come out of Canadian society. And we've already heard that every family is affected, and I think that's true. And when it comes to a criminal justice perspective, you think about there's about 10 million active criminal records in Canada. So if you overlay that with those people who are dealing with mental health issues and those people that are dealing with addiction issues, and you look at the intersection of those three things, there's probably not a family amongst us that somehow has not been impacted. I also want to end by offering some suggestions, what I hope to be practical suggestions, about how we can better respond to some of these issues. So that's what we're going to try to do. I want to start, though, by telling you a little bit or reminding you a little bit about my office, because many Canadians are gobsmacked to find out that they have a correctional investigator. It's not the kind of thing that you would normally think of, that there is an ombudsman for federal offenders, and I get asked often about why that would be, and that's another whole discussion. But I will say that we're established in legislation. The office is styled as an ombudsman. It was created in response to a bloody and deadly riot and hostage-taking at the old Kingston Penitentiary, which, after being the longest continuing serving penitentiary in North America, was finally decommissioned in September of 2013. But in 1971, there was a bloody incident there, and in good Canadian fashion, that incident resulted in a commission of inquiry, and the commission of inquiry resulted in the Office of the Correctional Investigator. And in typical government fashion, with alacrity, after promising to create legislation to give the office its statutory authority in 1971, and they were going to do that quickly, in 1992, they did. And the Corrections and Conditional Release Act was proclaimed into law. The office is absolutely an independent office. It's independent of the Correctional Service of Canada, and it's independent of the Minister of Public Service. I am appointed by order and council. I do not take direction from the Minister or from the Commissioner. We have our own staff and our own funding. And I can tell you that in the 10 years that I've been in the position, pretty near the 10 years, I have not been interfered with. And I've served with 2 different governments and 5 different ministers and 6 different deputy ministers and 3 different commissioners of corrections, and I've outlived them all. And I plan to continue doing that for as long as they'll let me, and they've never interfered with my office. The office is an oversight body. We're a very small office. There's about 35 full-time staff in the office. And they have access, what we call golden key access, to absolutely everything in the domain of the Correctional Service of Canada. So any place, person, file, document. And in fact, the legislation goes further than just access to anything under the control of CSC. It actually says any person. So from time to time, I've had interesting phone calls with law enforcement agencies and Crown Counsel offices and things about saying, hi, this is the correctional investigator and I want a document. And if you don't give it to me, I can subpoena you. And I suggest you look at the penalty section if you don't cooperate. And so you have some interesting conversations. My staff visit the penitentiaries regularly. They spend hundreds of days inside the penitentiaries, interview thousands of staff and inmates every year. We work to resolve the complaints that are brought to our office at the lowest possible level. So we work right at the site to try to resolve issues. In fact, my staff are extremely successful at resolving thousands of issues. The most frequent complaint that comes to my office has got to do with healthcare, quality and access to healthcare. And they work hard. And it's only when I interfere that their job doesn't get done, when I take an issue and then I decide that I'm going to deal with the commissioner or move it up. So that's the office, independent, public accountable, and small. And as they say, it's an ombuds office, not an advocacy office, but an ombuds office. Mental health and addiction in Canada. We're told that 1 in 5 Canadians will experience a mental illness in their lifetime. We're also told that 10% of Canadians currently live with a diagnosed mental illness. Canadians are the highest per capita users of psychotropic or psychiatric medications in the world. 1/3 of all hospitalizations in this country are due to mental illness as either a primary or a secondary diagnosis. Annual losses to the Canadian economy due to mental illness are estimated to be $33 billion. And every dollar spent in mental health and addiction treatment, we're told, saves $7 in down-the-road health costs and $30 in lost productivity. So with all that demand, we know that early intervention and treatment is a good investment. Persons living with mental illness have much higher rates of abuse and addiction than the general population. It's estimated that nearly 1/3 of people diagnosed with a mental illness also have a concurrent substance abuse issue. We know that people living with concurrent disorders have the highest risk for harm, experience the poorest system outcomes, regardless of the system, health, education, criminal justice, experience the poorest outcomes and incur the highest system costs. They are more difficult for service providers to reach, less accepting of treatment, and more prone to relapse. Research has established that the effects of living with mental illness and addiction is associated with increased risk across a wide number of domains. So, for example, related to depression, suicide, homelessness, poverty, social marginalization, victimization, physical health problems, including multiple sorts of infections and communicable diseases, criminal justice system involvement, and ultimately incarceration. The impact of concurrent disorders come into even sharper focus when it comes to incarceration, where mental health issues are more than 2 to 3 times more common than in the general population. Consider that since 1997, the proportion of newly admitted male offenders with a significant identified mental health need has increased by 71%. In 2007, just over 11% of all federal offenders had a mental health diagnosis at admission, and over 6% were receiving outpatient services. 30% of women, compared to 14% of men, had previously been hospitalized for a psychiatric reason. Think about that. 1/3 of the women admitted to a federal penitentiary had a previous psychiatric hospitalization. CSC screening at admission indicates that more than 60% of offenders now entering a federal penitentiary are flagged as requiring some sort of follow-up mental health service or assessment. The percentage of federally incarcerated offenders prescribed medication for psychiatric reasons at admission almost doubled between 1998 and 2008. A recent snapshot indicates that 63%, almost two-thirds of federally sentenced women, were prescribed a psychotropic medication of some kind during their sentence. For men, 80% of offenders also had a serious substance abuse problem identified at admission to penitentiary. And over half reported that alcohol or drug use was a factor in the commission of their index offense. 90%, 9 out of 10 offenders diagnosed with one form of a mental disorder suffer from at least one other disorder. Recent research from CSC in this area suggests that the outcomes for offenders with concurrent disorders are generally poorer than those with substance abuse or mental health disorders alone. On comparison, offenders with concurrent substance abuse and mental illness had the highest risk and need ratings in the areas of employment, attitude, negative associates, and community functioning. They had more extensive criminal histories. They're more likely to incur both serious and minor institutional charges. They had higher rates of admission to segregation, to isolation, and when they're admitted to segregation, they tend to stay there longer, and they're more likely to reoffend. This is a significantly ill and vulnerable population. Now, if we look for a second at the implications of managing this intersection between mental illness and addiction in federal corrections, it becomes clear that we need to take a look at the way in which the Correctional Service of Canada has developed their strategies for programs, for treatment, for access to health care, and to see whether or not they are recognizing the degree to which they are dealing with this concurrently disordered population. One of the things that I recently looked at was CSC's anti-drug strategy that focuses on substance abuse programs and treatment, prevention, and harm reduction measures, as well as interdiction and suppression activities. Now, little sidebar, we know that integrated care is the best practice recommendation for treating people with concurrent disorders. Unfortunately, even in a community practice, there is often insufficient coordination between mental health and substance abuse programs, clinicians, and support workers. The lack of integration is magnified many times over in a correctional setting, where screening, diagnostic, and treatment interventions remain too isolated, too uncoordinated. Even as concurrent disorders are becoming the norm, they're expected, integrated treatment remains the exception in federal corrections. Providing care in a prison is expensive. The average annual cost for a male offender in a federal penitentiary is about $114,000 a year. A little less if you're in minimum security, a little bit more if you're in max. For a woman, the average cost is much higher at approximately $215,000 a year. If that man or woman is being held in one of the 5 regional treatment centers operated by the Correctional Service of Canada, you can add about another $70,000 a year to those costs. CSC programs and treatment are expensive, and they can be effective when they're delivered at the right time by qualified staff to motivated individuals. But of course, capacity has to be equal to demand. To ensure that the greatest return on the $2.6 billion Canadian taxpayers will spend on their federal corrections system this year, we need to make sure that practice follows evidence and that ill offenders receive the support that they require in as therapeutic an environment as possible. To help create that kind of environment, CSC has set some ambitious goals. This is one of them: to totally eliminate illicit drugs from its institutions. Though laudable, such a goal is not likely attainable for the simple reason that living with drug dependence and addiction in a prison creates its own laws of supply and demand. Frankly, I'm not aware of any prison service in the world that has been successful in banning contraband substance out of its facilities. In corrections, the use of intoxicants is an illegal and an underground activity, making it difficult to measure and monitor. On the interdiction side, CSC is reporting year-over-year increases in the number of drug-related seizures. But of course, we don't know how effective that is because we don't know what the baseline is. In 2012-13, there were 2,366 drug seizures compared to 1,503 drug seizures reported in 2007-8. I too don't know what that means. There were more random urine analysis screens being conducted in federal facilities than ever before. These tests too are expensive. When results are controlled for regulated prescription drug use, the rate of positive urine analysis returns is now running at about 6.3%, which is a modest decrease from the 7.2% a few years earlier before the strategy was implemented. To emphasize the goal of drug-free prisons, in August of 2008, the Minister of Public Safety announced a 5-year, $120 million investment in the Correctional Services Anti-Drug Plan. The strategy includes the following interdiction and suppression measures: deployment of drug detector dogs at all operational sites, hiring of new security intelligence staff, purchase of advanced detection technologies such as ion scanners, and more stringent search standards at all principal entrances. Significantly, nowhere in that funding announcement was there any allocation for new money for substance abuse programming or harm reduction strategies. Of course, we know that the prison drug problem is also a public health problem. In 2011-12, based on a combination of self-reported and documented test results, the prevalence of infection amongst the inmate population for hepatitis C, for example, was over 30%, 15% for latent tuberculosis, and 4.6% for HIV. To put these numbers in perspective, federal inmates are 7 to 10 times more likely than the general population to be living with HIV and 30 times more likely to be living with hepatitis C. According to a 2007 inmate survey, 17% of women, 17% of men, 14% of women injected drugs in prison. About half of those who injected drugs shared injection equipment, including people who knew they had HIV, hepatitis C, or people who were unaware of their infection status. CSC began offering an opiate substitution program on a limited basis in 1998 as part of a new measure to contain the spread of HIV and other infectious diseases. Over the years, there's been a steady and a consistent demand for this program. Last year that we have statistics for was 2011-12, and according to the data there, 6% of the federally incarcerated population was enrolled in this opiate substitution program or methadone maintenance treatment program. The objectives of this program were to decrease the number of intravenous injections, reduce relapse, assist and motivate offenders to gradually disengage from illicit drug use, and decrease criminal behavior and incidents of reincarceration. Good goals. For 2011-12, the cost of this program was just over $11 million annually, most of which is accounted for in the salaries of the people who administer the program. Despite many positive attributes, as part of CSC's contribution to the government's overall Deficit Reduction Action Plan, or what we lovingly refer to in Ottawa as DRAP, the opiate substitution program funding will be reduced next year and ongoing by about 10%. It's concerning that the CSC is reducing its overall capacity to deliver this program as results are proven and as demand for it increases. With respect to other harm reduction measures, CSC makes bleach and condoms and lubricants and dental dams available in all of its facilities. although inmates occasionally report problems of accessibility and privacy. CSC has canceled, however, its Safer Tattooing pilot program and its rejected calls for a prison-based needle exchange. In the report from my office that was issued at the end of 2010, I indicated that the science and medical literature on prison needle and syringe programs suggests that these initiatives reduce risk and the spread of infectious blood-borne disease that arise through needle sharing, do not increase drug consumption or injecting, and do not endanger staff or institutional safety and security, end quote. My sense is that despite the evidence and the consensus reached by the research communities, a prison-based needle exchange program simply does not factor into the new interdiction-focused zero-tolerance approach to drugs in prison that is currently in place. Now, to its credit, the Correctional Service of Canada has fairly robust and regular immunization programs, surveillance programs, and screening protocols for a wide range of infectious diseases. These activities are complemented by public health awareness campaigns, staff training, literature on healthy living inside a prison. Indeed, the total public health expenditure is relatively modest, $13 million, against a total healthcare budget of just over $216 million. But the range of activities is impressive, and it would appear to resemble what's available in the community. There are other concerns that add to the complexity and challenge of safely managing concurrent disordered inmates. For example, there's an unusually high correlation between prison suicide and those who struggle with both addiction and mental health issues. In 2009-10, there were 9 suicides in CSC facilities. 7 of the 9 who took their own lives had ongoing substance abuse problems. 5 had committed drug-related offenses. 7 had an identified mental disorder, and 2 were considered to have mental illness, but they were not diagnosed. All 9 were on prescribed antidepressants at the time of their death. In the 4 prison suicides reported by CSC in 2010-11, all 4 had mental health concerns, and 3 were identified as abusing drugs and alcohol. All were taking prescribed psychotropic medication at the time of their death. In a series of annual reports and systemic investigations, my office has pointed to some directions for reform in mental health service capacity and delivery. Firstly, create intermediate mental health care units inside federal penitentiaries. These would be units for people who have problems in general population, but they're not ill enough or not yet diagnosed, so they can't gain access to one of the treatment beds. Second, to treat self-injurious behavior as a mental health and not a security issue. Prohibit the use of long-term segregation for offenders at risk of suicide or serious self-injury, as well as for offenders with acute diagnosed mental illness. Expand the range of alternative mental health care service delivery partnerships with the provinces and the territories, and appoint an independent patient advocate or quality of care coordinator at each of CSC's regional psychiatric facilities. We also think it would be a good idea to provide 24/7 healthcare coverage at all maximum and medium and multi-security level institutions. Significantly, many of these same measures were recently recommended by the December 2013 Ontario coroner's jury after the inquest into the death of Ashley Smith. I am more convinced today than ever that these measures would have a beneficial impact on the service's ability to more safely manage mental health disorders while assisting more of those who struggle with chronic substance abuse issues. The key is to move away from a security-focused first response to actions and behaviors that are driven by mental health and substance abuse disorders. Meeting the symptoms or manifestations of these disorders with pepper spray, with restraints, and with long periods in segregation or isolation is not therapeutic, it is not conducive to positive mental health functioning, and it does not enhance public safety. Co-occurring disorders represent a major healthcare and public safety challenge. In the criminal justice area, we need to better understand the incidence, impact, and interplay between addiction and mental health disorders and criminality. Within corrections, there is a need to change the lens through which prison drug use has been predominantly filtered. Interdiction and suppression in the absence of more comprehensive range of treatment, prevention, and harm reduction measures will never defeat the demand or supply of drugs in prison. CSC's anti-drug strategy must include a balance of measures that are better aligned to the needs of offenders whose criminal activity is linked to their addiction. We should be under no illusion of what is possible. Prison is the bluntest of instruments. It does not easily bend to the needs of mood or behavior or craving. Near total isolation and separation from supportive networks in conditions of confinement that are often crowded, cramped, noisy, violent, is not likely to improve the lives of people struggling with concurrent mental health and addiction issues. There must be restraint on the criminalization of mental illness, poverty, homelessness, and substance abuse in our society. The range of prevention, diversion, and community treatment options, including drug treatment and mental health courts, need to be expanded. Changing Directions, Changing Lives, Canada's first national mental health strategy, recognizes the need to implement more upstream solutions to focus on early detection, prevention, and treatment options with the aim of avoiding unnecessary or recurring contact with the criminal justice system. Finally, the continuum of care that we often hear so much about, both within and outside the correctional system, must be more than just a slogan. When offenders are returned to the community, there must be clear discharge plans with uninterrupted access to mental health and addiction services. Without basic levels of support, including, most importantly, safe and stable housing, community interventions designed to address the links between mental illness, addiction, and criminality are not likely to achieve much success. I want to thank you all for coming tonight. I want to thank you for the invitation to be here and for organizing this forum. I guess this is where we get to the dialogue part, and I'm looking forward to it. Thanks again.
Come and join. Thank you very much, Howard. Please join us. And I'm going to ask May and Dr. Boyd to join us as well as we begin to open up the dialogue portion of tonight's event. Come on up, May. I will take notes so that if there are questions that come. I'm going to ask each of our panelists to use the mic. We are capturing this, and we want to make sure that you have a chance to have your voice captured. So there are mics right beside you. I want to start by, first of all, bringing Dr. Boyd and Neil into the conversation before we go to the audience. We haven't had a chance to hear enough from you yet, and I'm wondering if you can help us set the context a little bit and talk a little bit about the extent to which federal criminal law and justice policy is developing out of an evidence base. Is it doing that? How is it doing that? And if you could set the context for us of the policy environment in which we are in.
I don't think that
I'm going to get you to use your mic. Oh, hopefully not. No, there we go.
Certainly since 2006 and the election of the Harper government, and particularly since the time of having a majority government, I think it's fair to say that the direction of criminal justice policy has been very much away from evidence and evidence-based findings. From my perspective, I look at the mandatory minimums in the realm of drugs as just fundamentally tragic, a mistake of huge proportions. This was something that we began 100 years ago. It wasn't until 1908 that we even thought globally about the criminalization of certain mind-active drugs. And it's quite clear, that the choices that have been made aren't choices that have very much at all to do with public safety. In fact, they serve to undermine public safety. I think one of the interesting developments over time is that you now see these remand populations in correctional centers that in every province have been growing at a time when crime rates are actually declining. So how does that happen when crime rates decline? There needs to be some better explanation of that, why it is that remand populations are growing, but crime rates are actually coming down. In some ways over the last 30 years, there has been a sea change. If you look back to what used to happen to people who did heroin and how they were treated by police, and if you look back to the way people thought about drugs and the line between legal and illegal drugs, you'd think, well, how could this possibly happen? Because on the one hand, there's this very much an increased knowledge about what this means, but on the other hand, these policies that the Harper government has come forward with, they're very cynical, it seems to me. They're not based on any kind of evidence. They've led, as I said, to a growth in remand population, to some growth in the prison population as well. It was said earlier that this is not a moral issue. This is a public health issue, and these are people. Many of these people are people who have significant mental health, substance abuse problems. It's a public health issue. And I think for them it's a moral issue. It comes back again and again. Their challenge to insight was quite remarkable. I guess that's about as stark a contrast as one can imagine.
So just for the novice in us, remand meaning the pretrial?
Yeah, people who are there awaiting trial. And it just doesn't really make sense to me that when crime rates are coming down, remand population should be increasing.
Okay. What I'm going to do is open the floor for questions from the audience. We have some people with traveling mics, Jasmine and Janet over here. Please indicate if you have a question, and I'll get Janet right here, first question and then the second question. What we're going to do is we're going to take these first two questions before we go back to the panel, and that way we have a chance to hear more from you, and then we'll come back to the panel.
Hello, my name is Hendrik Buren. I live in a supportive housing situation, and people often experience mental health crises of some sort, anxiety attacks or whatever. In my experience, it's very difficult to get adequate support. You can ask the staff for it. You can call a car 87 if the staff can't help you. But usually what happens is the police show up. And in my experience, the police are not very helpful. Could they have possibly better training to deal with mental health cases and not make it a criminal issue right away?
Okay.
What's your experience with that?
Wonderful. We're going to come back to that. And in just a minute, we'll take one more question at the back, and then we'll come back to that.
I'm curious about prisoner reentry programs like federal parole and how mental health and addiction issues could fit into the way we impose conditions on people's parole or any kind of community supervision order. It's an area I'm interested in hearing more about.
Okay. And your name is? Just have a chance to introduce yourself.
William Damon.
William, thank you so much. So Henry's question, I'm going to go to you, May, first in terms of the mental health crisis. It's difficult to get adequate support, and the police are usually the first to arrive. Tell us a little bit more about, from your perspective, on that, and then we'll go to Howard.
There are some other people here from Grief to Action who have direct experience with this. And Barrett, you might like to make a comment because you work in this situation as well. I think it's really unfortunate that there isn't enough support. At least there are some supportive housing, but obviously there needs to be other kinds of structures put in place so that people have that kind of comfort and aid 24/7, because that's what's needed. What I do see happening, and I think that we should find really specific ways to get on it and make it happen more, is I do see, and people can contradict me if they don't see this, but I do see the Vancouver City Police trying to train people. They've, sort of assigned someone to that special training. And I think that, as Neil said, there's a greater awareness building, but there's so much to be done there. And Delta City Police, I don't know if anyone came here tonight from Delta City Police, but they just recently did a very good survey, study, research, and are wanting to put in place training for police officers to be able to handle situations, and not just in a disciplinary way, but in a caring way. Because I think it's not that we need a whole new police force and another 50,000 guys. It's that we need people to understand the comfort that people need when they have mental health issues or when they're in trouble with their addiction. So it's not like we need a lot more people. We just need people to be kinder and more educated and more understanding.
Howard, over to you.
Oh, okay. There's no doubt that the police community has identified this as a priority. About a year ago, I was at a national seminar that involved Crown prosecutors and judges and police leaders from across Canada, and it was focused on how to better respond to mental health in the community. So it's a priority, and training is there, and there's awareness there, and there's money, and there's resources, and it's being studied. But the reality is that we have policies that trip over each other. So I'll give you an example. I've reviewed a lot of files of people whose journey into the criminal justice system started in an emergency room in a hospital. Somebody's in trouble, they're in crisis, they want help, they're not really very polite. Guess what? We have zero tolerance policies in hospitals. If you don't behave yourself well at the triage desk, somebody pushes a button, security comes, they take you away, they call the police. The police are to remove you. So even when the police are trained, and even when the police have discretion, there's this other policy, the way our hospitals are run. So it's not just the criminal justice community. There's this interaction between all of these big systems, and that I think we have to address. Training has been a huge focus in corrections as well. And as much as there is greater awareness in terms of mental health and behavior, in terms of suicide prevention, the use of emergency response to somebody in a mental health crisis is increased. And those folks don't go into treatment beds, they go into segregation cells. So even when we know better, we tend to replicate some of the stuff that we know doesn't work.
Howard, while you have the mic, maybe you can address some of William's questions related to the prison entry programs.
Well, how I understood the question, and William, you'll have to tell me whether I got it wrong, was really about conditions on release and whether that's helpful or not and whether it works or not. I think that it's a mixed answer. In the Pacific region for the Correctional Service of Canada, they probably do a better job in the transition from institution to the community than in other places in the country. Also, institutions in this region, in the Pacific region, are less crowded than certainly the institutions in Ontario or across the prairies. And so there's a little less pressure and a little bit more time. And those two things tend to make a difference as people get handed off from the federal corrections system to a community health support system. And so we've seen some success. Conditions, though placed on conditional release, can be problematic. And I say this as an ex-parole board member making all kinds of mistakes in release conditions imposed at the time of release. So you place geographic conditions on somebody. You place conditions that say you cannot be with anybody who's known to have a criminal record. You place conditions on an addict that says you have to be sober. And then you wonder why we have such high return to prison, not for the commission of a new crime, but because of an administrative violation of a condition that was really a recipe for failure. And so even when you get the handoff done right, and you get people into support, you get people into housing, you get people into therapy, you can still trip them up simply because being wrong-minded about what's the best way to supervise their release. So I'm not sure if that's what you were getting at, but...
Got a couple of other questions. One question here and another question there.
My name is Jun Trinidad, and I did my residency chaplaincy in Alberta Hospital. And my experience with the patients, I was part of the team in the assessment if they're NCR or not. Practically, there was only one patient who said, "Send me back to remand." But all of them were saying, please don't send me back. Please don't send me to that prison center. I would rather stay here longer, but don't send me back. So what I was hearing was, could there be a possibility of interfacing programs, in the federal system and what they're experiencing in the hospital psychiatric forensic system? Because if that's what they felt, don't send me back. Maybe they could learn from each other, because mental illness or mental issues are present in both. So.
Thank you. And just over here, there we are.
Hi, I'll try to keep this quite short. My name is Rob Rattan. I'm a former prosecutor, and my wife Susie and I were founding members of From Grief to Action. We have a son who suffers concurrent disorders. 15 years ago, he struggled with heroin. Just this last year, he relapsed into heroin use, and ultimately he ran afoul of his dealers, became desperate, armed only with a note. He went in, robbed a bank, one bank after another, until he was caught. And he's, because he opted that route to get money rather than dealing, he wasn't a candidate for drug court. So this is in Montreal, so he's in federal penitentiary now, serving a lengthy sentence. My question is, how does a parent who is concerned about the health care that their son is receiving in a federal penitentiary intervene or raise their concerns? And just very quickly, 3 of our concerns are, I said concurrent disorder, it's bipolar disorder and addiction. So he struggles with depression at times. He broke down once he had gone through withdrawal and was clear enough to fully appreciate where he was. He went through a terrible state of breakdown, and the way this was treated was, he must be suicidal. He was stripped and put into a solitary cell, cold, no mattress, and basically learned from that he better not admit to his suicidal feelings again, or he'll be effectively punished. The other health concern, one of the other ones, is his cell was searched a week ago. When he got back into his cell, all of his stuff was tossed about, precious letters torn, photos torn. After they left, he broke down, smashed his fist against a window, broke his hand. They wouldn't let him see a nurse or a doctor. He finally, though it was his right hand, managed to make written requests. Finally, after 3 days, got an x-ray. It was confirmed he had a broken hand. But still, here it is a week later, he still hasn't been able to see a doctor. So we're concerned about that, though it's well beyond setting the bone time. And then the last area is in the methadone. Now, we greatly appreciate that it is important to make methadone available to heroin users. But having been off heroin for most of his life, and this relapse being fairly recent, he was determined to get free of opiates. He suffered through withdrawal 2.5 months ago, and he doesn't want to go on methadone. But they keep offering it to him, And lately he's been told a refusal of recommended treatment will hurt your parole chances. So we are concerned about his health care. What do we do?
Thank you, Rob, very much.
He wanted to start an AA group. They wouldn't let him because it's being offered in another range, one to which he has no access. But we have... So...
Thank you very much for...
Sorry that was so long.
Thank you very much, Rob, for bringing all of that into this discussion. No, it's important. Howard, do you want to take a start, and May?
I receive phone calls and letters that share experiences that remind me about the work that I do and the reason why the office exists. They're not the statistics that I talked about, and it's not the percentages, and it's not, it's not the sort of antiseptic language of, concurrent disorders. It's people's sons and daughters and brothers and sisters and wives, and they're not just criminals. They're people. They're not just, offenders. I use the word offender and I use the word inmate, or even the word patient, but that doesn't define them in their totality. There may be people who are ill, and there may be people that have had an unfortunate incident, or maybe even have been violent, but there's a whole range. Like they're fully formed human beings, and we forget that. And the system forgets that, and they forget that they're part of families. And I have parents who travel cross-country to go visit on their appointed day to be told, I'm sorry, there was an incident, we're locked down, so, but I've only got 48 hours, I'm here now, no, I'm sorry, you can't get in. I have families who want to send books into the institution, and they're told, well, no, we don't, it's a fire hazard if we had that many books in the cell, one of them was told. Those aren't approved. Or go to the library, but of course there isn't a prison library. The concerns about health care, the access to health care, people who have managed chronic health conditions in the community before their sentence, who are being told you can't manage your own health now. People who have decided to deal with their illness through diet, being told, no, that's not recognized here. You can get a religious diet, but you can't get a healthy diet. And so, I would love to talk to you about how we can support what you want to get done, and I'd be happy to do that today or electronically or over the phone. There are things that we can do. There are interventions we can make. It is very key that with your son, as with any individual, that we are free to talk with you about him, because there are privacy concerns. But there are interventions, and there are things that can be done, and I'd be happy to work with you about how to best address those concerns. And in saying that, it frustrates me because these concerns happen 1,000 times a year, and we have to solve them 1,000 times a year. But if that's what it takes, and it's because the system is really designed and calibrated to meet the needs of the system. And, your son's an outlier.
May, let's take that question and look at it from a family perspective. Grief to Action exists to try and address some of these issues and be a support network. Tell us what families can do in this context when you're facing barrier after barrier after barrier for your child in prison.
Well, here's Susie and Rob asking, what can I do? And they're pros at what we can do. One of the things that strikes me about this conversation is that we have to bring it to the level of people really understanding how really mean we are, how cruel we are to people with mental health and addiction issues. Like, where does that come from, and how can we humanize that? That's something that's much more than just a family can deal with, but we have to really call people on the utter lack of compassion, of throwing somebody nude into a cold cell because they want to commit suicide. Like, maybe they should have a hug instead, So that's sort of one thing. But the other thing is that we really have to be able to speak out loud about these things. And then I think families, much as they struggle to be able to make contact with someone like Howard, we also have to really learn how to look after each other. And it's kind of odd saying this to Susie and Rob, but we have to know how to set some boundaries so our heart is not broken every single day, and that we're not just rags all the time, so that we can survive as well. And that's why there's family support groups like From Grief to Action, and we have to really look after each other and remember that our kids are just our kids, and sometimes they're really out of line, but nobody should be treated as cruelly as our children are. not just in the prisons, but the whole system. I see it with addiction doctors. I've met some very nice addiction doctors. There's people like Evan Wood, but there's an awful lot of people out there that are just mean, my way or the highway. And if you don't do it like that, you're going to be stomped on like a bug, and that's it. And that's what we have to really start challenging, is that we have to bring some kindness and some humanity and compassion into this whole thing and look after ourselves.
Neil, I want to bring you in on a conversation that, is it Jura? Yeah, raised, and that is around those that don't want to go back to remand. What's the possibility of creating any kind of program or relationship or interface between those that have to go to remand and the psychiatric wards that are servicing them? And that may or may not be a question you want to take or Howard wants to take. It's a tough one.
I think it's probably ultimately a question that Howard's much better able to take, but I thought one of the interesting points you raised was around that issue of people not wanting to go back, and how has that happened? We've had deinstitutionalization, we've had failure to build supportive housing. During the 1990s, the Liberal government of Jean Chrétien got completely out of business of building supportive housing, so that what we take now for granted with the disability that we see, so the lack of caring, in a sense. Sometimes it was just shunted away in institutions 30 years ago, but we've also seen, I think, as a consequence of very deliberate policies over time, the sort of change that you describe, and a kind of collective failure to meet the needs of people who are suffering. But I'll turn it over to Howard for the specifics.
There are some examples across the country where that relationship works much better than it does in other places. So, for example, St. Lawrence Treatment Centre in Brockville, Ontario, it's a forensic jail run by Ontario Corrections, but it's actually run by Ontario Health. So Corrections does the perimeter security, but it's a healthcare facility, and they don't refer to inmates; they refer to patients. And if you're in that center, you're there because you're a patient and you're ill and you're receiving hospital-based care. And there's a continuity of care. So past warrant expiry before trial, it covers your needs. So there's some good examples. There's examples really across the country. British Columbia provincially has changed the way that they organize and deliver their healthcare services. In Halifax, there's a co-located provincial jail with a psychiatric hospital. I'm hopeful about that model, but I have some concerns because when I visited it, they talked about the hallway that connects the two facilities, the corridor that connects the two facilities. They referred to it as the Green Mile, and that kind of concerned me a little bit. But they're trying to better integrate those systems, and it seems to be the provinces that are leaders in this, not the federal government, and that makes some sense. Healthcare is provincial responsibility, and so it might be a little bit easier to integrate those services. Other countries have done a much better job. They're much further ahead. New Zealand's much further ahead. Scandinavian countries are much further ahead. The UK and the National Health Service and their involvement in Her Majesty's prison system, much further ahead. So there's some lessons internationally we could learn as well, because it's a very important interface. It's the same person. Today they're in a hospital room, and tomorrow they're in a remand cell. It's the same person.
Thank you. Let's take two more questions. And we've got a question here. And am I missing someone at the back? We also have a question a woman in the red as well. So question right here. Yep, there, and then the woman in the red.
I have. Is this on? My name's Ann Livingston. I work with the Vancouver Area Network of Drug Users and worked organizing drug users into a drug user group where they have their own voice for many years. And I'm always horrified when I hear about now a mental health court after the community court, after the drug court. Because I'm seeing the people that are sort of chewed up through all these courts, and they're doing life in 3-month bits at remand, and they're not even found guilty of something when they're back in remand awaiting trial because they missed another court date. And William, I think, was trying to get at some of that. So the Cowper report does a lot of discussion around this phenomena, and we have really thousands and thousands of people not in the federal system. And I don't know if they end up there, but it wouldn't surprise me, or that they end up dead, or they're the same people that are shooting dope in alleys just a few blocks from here. And they have no hope of anything. And one of the things that, since this is a dialogue with SFU, and one of the crisis points in this province is in Surrey. And we've made, for 4 years, there's been a group of drug users meeting in Surrey, because I'm crazy enough to go out there as a volunteer and do it, because it's so bad. And I was thinking if there was a comment about preventing the whole damn mess in the first place by really organizing in the communities and saying, you know what, we're Canadians, and we're going to get heroin prescription, and we're going to have injection sites, and we're going to have the best public health there is, and we're going to do it because it's the right thing to do. And we're going to have those awkward, difficult conversations, and we're going to have to tell the police that you can market somewhere else, but please stay out of our kids' addictions and stay out of our people's mental health. You are not going to be frontline workers in our healthcare system. And that's what they've done. In this neighborhood, they're now picking up people by the thousands or hundreds and taking them to St. Paul's. St. Paul's, I don't know if you've just seen how the police have now put out 4 or 5 reports about how they're the frontline mental health workers. But they're criminalizing people, and they're ending up with these mental health police reports so that no matter where you go for the rest of your life and try and get a job or act as a volunteer, it's going to say that you got picked up for a mental health incident with a little attached description of the incident. So I don't know if there's I guess it's a challenge to SFU to get involved in the community, get involved in Surrey, be able to have these dialogues. There's nothing going on there. I swear there's more drug addicts in Surrey than the rest, any concentration in Canada that would be. It's a bigger hotspot now than the downtown east side. Anyway, it's sort of a challenge back to SFU, and then any other comments of whether they do end up in the federal. I've heard of people asking for federal time because they thought they could get treatment. Well, I bet they were sad later. But anyway, that was their delusion as a criminal.
Thank you, Anne. Go for the final question. And I think it was the woman in the red. Yes.
Oh, hi, it's Diana McKenzie. What I'm really curious about this evening is I've been reading a great deal lately, but the higher proportion of Aboriginal peoples who are incarcerated, a significant number of them, if they're not suffering from the intergenerational trauma, are survivors of residential schools. And I wonder if someone could speak perhaps to what seems to be racial typing and that overwhelming proportion within the prison populations.
Okay. So we're going to start with May and then allow each person, because this is our final round.
Okay, Anna. Is this on? Do I have to do something?
I think you can just start talking.
Okay, Anne, thank you very much for bringing up what you did. I want to just, my son has had a lot of experience in Surrey. He's had a lot of experience in those support recovery houses. Apparently there's 180 of them in Surrey. Apparently there's 130 of them in Coquitlam. They're allowed to exist because who cares? And what goes on in those treatments, I really think that we have to go after the deregulation that happened to allow that kind of situation. People need somewhere to live, and so lots of times they'll say it's a wee bit better than a shelter to live in a support recovery house. But that is where a lot of the further addiction happens, where a lot of targeting happens with dealers, where a lot of people, young people are taught really, much more criminalized kind of behavior. And it's sponsored really by the government allowing it to happen, by the municipality allowing it to happen. Now, we can't just shut those down because there's 20 people in each of 180, so that's a lot of people without a home. But what we've got to start doing, I think, is targeting some of those places and make them so that they are much safer places to live, and so that there's some kind of rationale and some kind of, proper food and some kind of, staffing so that people just can't use it as a drug house. So that's one of the places that I would certainly want to put some energy on a political level, as well as on a public awareness level. So, and you're right about Surrey. Surrey, New Westminster. I mean, people talk about the downtown east side all the time, but it's not all about the downtown east side.
I'd like to pick up on the same points that Anne was raising. It's really striking when you go to Europe and you see in Zurich how they've transformed themselves and how they have a number of prescription sites. They have a number of supervised inhalation and injection sites. It is not a moral issue. You start to wander close to the sites and you realize where you are, and you recognize that there's no sense in which this is dividing a community in the way that it has here, or in the way that we've kind of almost allowed federal politicians to permit that sort of division over time. I mean, at the same time, we've changed as a culture. I mean, Stephen Pinker's written about this, why violence has declined. You know, we started with gay rights, women's rights, gay rights, children's rights, animal rights. I mean, this is another kind of right of a sort with mental health and addiction. It's a more difficult right for people to accept, and because of sometimes chaotic behavior, but it's the same kind of opening that we have to do, and opening of our eyes. And I think it's happened to a much greater extent in Europe. I think Europe's a lot more civilized than we are in many important respects. So it's about a greater humanity, I think, and it is as you said, I mean, it is a challenge for our university.
Howard.
I want to be really clear, Anne, and I appreciate part of the first part of your comment about, you know, we got these kind of court and that kind of court. I mean, specialty courts, and there's a variety of opinion about specialty courts, drug courts, or mental health courts. But I want to be really clear that that's all after the fact. The emphasis has to be on prevention. It has to be on what happens to the community. It has to be on the kinds of supports that we can bring to people when they're in crisis, not just when they're in conflict. And it's so many things that we've talked about in terms of people advocating for themselves and families looking after each other. And you know, the research is clear about prevention, about it being economically sound, about it being the most productive, about it having the longest. But then there's the whole criminal law reform piece about what we criminalize and how we punish. And you know, the police are between a rock and a hard place in this. I'm not sure the police volunteered. I'm not sure they stepped up and said, yeah, I want to be a primary mental health worker. I think that the police were frustrated too. So the people that I know in law enforcement talk about the frustration of going to the same place for the same kind of call time after time after time after time, and hoping and praying that nobody gets hurt, and hoping that they can do something that's going to be helpful. And then the frustration that what they're left with is a criminal charge. And the family members that beg sometimes and say, please arrest my son. And so, you know, my experience has been that you can get all of the players of the system in the same room and get them all pointing fingers at each other and saying, you have to do a better job. But the reality is that it's already too late, I think. And this ties in part, Diana, to your question about Aboriginal offenders and Aboriginal Canadians in conflict with the law. Prison is failure. Right? Prison is failure. Prison represents the failure of a whole bunch of other social policies. In this case, prison represents the failure of colonial practice. It represents the failure of dislocation. It represents the theft of culture. It represents failed policies of assimilation, including residential schools. Prisons are failure for Aboriginal Canadians. Prison is failure for Canadians suffering with mental health and addictions issue. And you can't expect prison, which is designed to separate people from society, to be the road to build society. Right? I mean, it doesn't make sense. We expect prison, we expect caging people up is going to be the solution to building healthy societies. You know, it doesn't make any sense. But I can tell you, as a politician, as a practitioner in criminal justice, as a student studying it, there's a whole bunch of people that want that criminal justice response when there's a problem. And so I think it's about, you know, sort of backing away from the argument. my job is about making prisons the best they can be. Think about how that makes me feel at the end of most days. Backing away from that and understanding that that's too late. When you have to call the police to get health care, we've screwed up. You know, and when we've got 1 out of 4 nearly federally incarcerated men and women are of Aboriginal descent, we've screwed up. That's not the kind of society we pride ourselves on building as Canadians, but it's the kind of society we've got. And so you have to stand back and think about how we got there.
Thank you. We won't go into that because we're just at the end.
There's a relationship.
So, Anne, also you threw a challenge at SFU. I wanted to let you know that the first week of the conversation with our brand new SFU executive director in Surrey, it was our very first conversation. It was all about support recovery houses, and we needed to have a dialogue on what the heck's going on there. So we hear you loud and clear, and we'll certainly take that for the SFU Public Square into our conversations with SFU. I want to now introduce Am Johal. I'm looking at Am Johal is our colleague here at SFU Woodwards, and Am, you're going to bring it all home.
Thank you very much for being here this evening. I wanted to take the time to thank Howard. I just met him tonight for the first time. May Burrows, who's done amazing work with the Labour Environmental Alliance Society, besides all of the work that she was talking about tonight. Neil Boyd, besides being very vocal and in the newspapers, met him in 1998 when he was on a panel advocating for the need for a supervised injection site at a time when it wasn't a particular popular thing to do. So thank you, Neil. And Shauna, who, before she ever came to work here at SFU, was working at the Institute for Media Policy and Civil Society in the 1990s, doing wonderful work. Thank you so much for that enriching discussion. Just wanted to let you know that we have about 100 public talks that we do here in this building. You can look it up at sfuwoodwards.ca. We partner with Public Square all the time. And this coming Thursday, one of the champions of this development, Jim Green, we're doing the Jim Green Memorial Lecture, which will be free at 7 p.m. with Bob Williams, a board member with Van City. It'll be a night of storytelling because Bob knew Jim for about 40 years. But whenever we finish our discussions, of course, they're never over, and I know a number of you had more questions, but we have the room for another hour. There's still more coffee and desserts and all of those kinds of things. So please do stay and talk. So thank you very much.
Thank you. Thanks very much.